at Jabstudiesmetfun. So this is going to be a very interesting and a very important topic today. I'm going to discuss in detail some discussions with respect to pericarditis, ECG and much more. So let's have a very enthusiastic and a joyful and a fun study discussion. The first thing what I'm going to talk about is the diseases which are involved in the pericardium. First thing which we're going to talk about is acute pericarditis. Acute meaning sudden of onset. First thing what they can ask you in questions is what is the most common cause of acute pericarditis? The first answer is idiopathic. Pata nahi. It's a fancy term to say that I don't know. Okay. So most common cause is going to be idiopathic. Second cause can be viral causes such as COVID-19, rheumatic heart disease. Let's add a PYQ. The characteristic feature in rheumatic heart disease is going to be Ashkoff nodules, something which is known as uremic pericarditis. Now, in some cases, guys, after a post-MI, like mostly after 6 weeks, you develop features of acute pericarditis. This is known as Dressler syndrome. Now, usually this Dressler syndrome is an autoimmune condition, hence an autoimmune pericarditis. Now, usually in autoimmune conditions, we give steroids. But guys, remember, that's why this question is usually asked. In case of Dressler syndrome, which is an autoimmune condition, we don't give steroids, we give aspirin. Okay, we give aspirin. Next, guys, let's know what do you get in the ECG with respect to acute pericarditis. In the ECG, guys, you get an ST elevation. Now, one might think you also get ST elevation in MI. So how do you differentiate between the two? Normally, if you see this an ECG on the top, the blue one, you have a P, you have QRS, and this is the T wave. Anything above over here, something is going to be an ST elevation, correct? Over here, if you see, this is the ST elevation which is seen in acute pericarditis. But on the other hand, if you make a difference with cases of MI, you see the ST elevation like this. So what is the difference you guys can notice? The difference you guys notice is there is a type of depression, which means in, fancier term again, it is you have a convex ST elevation in case of acute pericarditis, while in case of MI, there is a concavity. It's like a bulge in case of MI. So that's how you can differentiate acute pericarditis and MI in case of ECG. Other findings like on osculatory findings, you can have something which is pericardial friction rub. So anything pericardial friction rub, along with that a convex ST elevation, your answer is acute pericarditis. What is the most common cause? Idiopathic. Very good. Okay. Next condition, guys, let's talk about pericardial effusion. Decode it. Pericardial around the heart. Effusion fluid. Normal fluid which is present in the heart is like in the pericardial area is 20 to 50 ml. Anything above 50 ml is going to be pericardial effusion. What are the causes? There are two main causes with respect to pericardial effusion. One is going to be TB. So TB, pericardial effusion. Other conditions like oat cell carcinoma of the lungs can spread around the cardiac part and cause malignant pericardial effusion. Okay. What are the features, guys? Again, think about effusion. So it is going to be a bit swelling. So you are going to have cardiomegaly. What is cardiomegaly? Cardiothoracic ratio more than 50% or 0.5. Along with that, you have some features which is like a big water bottle like heart or a money bag like heart. ECG features which you have to remember is that you need to know there is something in the cases of electrical alterance. In case of pericardial effusion, you have something which is electrical alterance. You don't need to remember like what is the features in the ECG. Just remember the word. In case of pericardial effusion, you get what ECG feature? Electrical alterance. Very good. Along with that, the another feature which you see in case of pericardial effusion is you have a low voltage ECG. A low voltage ECG. So two things. One was electrical alterance and second is low voltage ECG. But now this low voltage ECG, guys, is seen in three other conditions. Constrictive pericarditis, hypothyroidism, and restrictive cardiomyopathy. Constrictive pericarditis, restrictive cardiomyopathy, and hypothyroidism. So why you have to remember is they'll be like which of the following conditions has low voltage ECG. They might ask again restrictive cardiomyopathy, hypo, constrictive, or all of the above. Answer should be all of the above. Very good. Okay. So these are the features with pericardial effusion. Next, guys, let's talk about a condition which we have talked twice already now. A very important topic, hence repeated twice. It is cardiac tamponade. Patient with a trauma, blunt trauma to the chest. Patient they will develop a kind of constriction around the heart, due to which a patient will be suffering from obstructive shock. What is obstructive shock? No blood can go past, due to which it will not be able to pass to the whole body. Hence, the patient will be having low BP. Triad is Beck's triad. What is Beck's triad? Muffled heart sound, S1, S2. JVP raised, hypotension. Diagnosis, cardiac tamponade. Very good. What is the management? Echo guided pericardiocentesis through the safe sternum, a 45-degree angle. Features which you need to remember: you get to see electrical alterance in cardiac tamponade also. You get to see electrical alterance, and you also get to see a money bag or water bag appearance. Why, guys? Because obviously water around. So you might notice one thing: in case of pericardial effusion and also in cardiac tamponade, you have two same features. One is electrical alterance, other is a money bag or water bag appearance. So how do you differentiate amongst the two? Another important feature which we talked about in case of cardiac tamponade was pulsus paradoxicus. So remember, guys, if you have in your question diagnosis in the ECG shows electrical alterance, along with that if you have pulsus paradoxicus, your answer is going to be cardiac tamponade. If only electrical alterance, no pulsus paradoxicus, you're going to have pericardial effusion. What is pulsus paradoxicus? Whenever you inhale, BP goes down. Whenever you inhale, BP goes down. Cool? So that's how you compare and study. That's how you retain information longer. Always try to integrate. Okay. So next condition which you have to remember is constrictive pericarditis. You can see in constrictive, see how I remember is C for constrictive, C for calcium type deposition. So you can see around the borders of the heart, around the borders over here of the heart, you can see there is calcium depositions. Correct? So you like opacities basically. So basically, what are the features which you see in constrictive pericarditis? This is also can be associated with respect to TB. Okay, features are, you will also again in case of constrictive pericarditis, you will have pulsus paradoxus. The JVP is going to be raised, and also you'll have a feature which is known as Kussmaul sign. Remember, we talked about Kussmaul sign in the last video, which means usually JVP falls down at time of inspiration, but during inspiration, if JVP does not fall down, that is known as Kussmaul sign. Which other features, where other conditions you see Kussmaul sign? 3. Remember, constrictive pericarditis, CRR, constrictive pericarditis, restrictive cardiomyopathy, and right-sided heart failure. Remember, CRR, that is for Kussmaul sign. Along with that, you have rapid X and Y descent, the last topic which we discussed in the last video. Correct? ECG features are low voltage ECG. Where remember we talked 3 conditions: restrictive cardiomyopathy, constrictive pericarditis, hypothyroidism, and pericardial effusion. Very good. Whoever is repeating with me, I'm very proud of you guys. Best way to study is studying right now. Speak and study, it will retain for longer time. Remember, guys, in case of constrictive pericarditis, a differentiating feature versus pericardial effusion and cardiac tamponade is the cardiothoracic ratio is going to be normal. Why? Because there is a constriction. Constrictive pericarditis, decode the word. That's why it can't spread much. Hence, the cardiothoracic ratio is going to be normal. And C for calcification. So C for constrictive pericarditis as well. Okay, to differentiate all what we have discussed right now, I have made another table over here. Remember, how do you diagnose acute pericarditis? Obviously, history, oscillatory fighting, pericardial frictional rub. ST will be concave. If you see convex, it is MI. In pericardial effusion, you have electrical alterance and low voltage ECG. In cardiac tamponade, you have electrical alterance, but differentiating what? By pulsus paradoxus, and you will have Beck's triad. Okay. In case of constrictive pericarditis, guys, you're also having pulsus paradoxicus, low voltage ECG, and Kussmaul sign. So over here, 4 diagnoses. Even if you don't have time to know too much detail about these conditions, know these details and you will be able to rule out which of the options are not correct in your question. Okay. Next, guys, let's talk about a very some people consider it very hard just because by how people learn it, but it's actually quite easy, and let's learn it in the easy way so that you will never forget again. Let's talk about ECG. Okay, so whenever we start with ECG, guys, first you need to know what are the types. What are there first? Okay, you have basically waves. One is going to be your P wave. Okay, the other one is going to be your QRS, and the other one is going to be your T wave. Correct? These are 3 waves: P wave, QRS, and T wave. Then you have intervals. One is going to be your PR interval, other one is going to be your QT interval. Simple, so far so good. 3 waves, P, Q, RS, and T. 2 intervals, PR interval and your QT interval. Now, what are the meaning of all these? Okay, first thing you need to know, what is P wave? P wave, guys, is basically your atrial depolarization. Okay, not autosomal dominant. If you're just watching the notes and not the videos, then you'll think like P wave kab se AD ho gaya, hai na? Maze kar rahe ho. No. P wave means you'll have atrial depolarization. PR interval, guys, is AV nodal conduction. Basically, when the transport of the impulse from SA node to AV node, that is signified with your PR interval, and that also signifies the nodal delay which is there in the AV node. Okay, QRS is nothing but your ventricular depolarization. Q alone is your septal depolarization, when the septa, the middle part of the ventricles, are getting activated. T wave, guys, is your ventricular repolarization, and QT interval is a combination of your ventricular depolarization and your ventricular repolarization. So far so good? Very good. You have a point, guys, that is known as the J point. Okay, J point is an isoelectric point. Let's decode it. What does it mean? If I just now told you what is this, what are these waves? This is P wave, PR interval, QRS, and then T. So if you see here, from till here, S is stopping, right? So J point, guys, is a point where S stops and T starts. So what it's trying to say is, it is a point where depolarization ends and when repolarization starts. Correct? So J point is an isoelectric point where there is no depolarization and there is no repolarization. It is the start of the repolarization and the end of the depolarization. This is J point. Don't get confused with J point or J wave. Okay. Next, guys, what I want you guys to know is where and where does it start? PR interval. One might think PR interval starts from P wave and ends with R. No. PR interval, guys, over here if you see, PR interval starts from the beginning of the P wave and it ends at the beginning of the Q wave. Very important. Okay. So you see PR interval, this is P, this is Q, this is R here, and S is over here. So see, make sure this can come also as a one-liner, guys. PR interval is going to be the beginning of P and the beginning of the P to Q. That is your PR interval. Okay. Next, you will have QT interval, starting of Q till the ending of T wave. Okay, that is your QT interval. Next, guys, which we have already discussed these all factors. So if you see over here in the ECG itself, this is your P wave, from here QRS. Okay, then you'll have your T wave. Another thing you have to remember, guys, Q wave is a negative wave. What do you mean by negative? If you see, this is the point over here, above will be plus, over here will be minus. So see, the Q wave is a negative wave, and over here this wave also, this is your S wave. So S wave is also a negative wave. So you can check over here, this is the Q wave and this is your S wave. So these both are your negative waves. Okay, 1 point. Next, guys, you need to find how do you calculate the heart rate. Heart rate is calculated by counting the boxes, counting the large boxes. Okay, counting the large boxes between 2 hour intervals. How do you do it? You have to take a number which is 300, divide by all the large boxes. Okay, 300 divided by all the large boxes, you will get the heart rate. Okay, so if you see over here, you have 1, 2, 3 and a half, right? So you see 300 divided by like 3 and a half, which almost gives you a value of around 82 or something like that. Okay, so that's why you can say the heart rate is 82 like that. What is the normal range of heart rate, guys? It is going to be 60 to 100. Anything less than 60, bradycardia. Very good. Anything more than 100, it's going to be tachycardia. Now, if you are a person who likes complications in your life, if you are a person who does not like the easy way out, you can calculate the heart rate even by counting the small boxes. So what you have to do is, you have to use this number 1500 divide by all the small boxes. Okay, all the small boxes between 2 hour intervals. That way also you can get the heart rate. Okay, I am not going to count it this way because, again, first of all, I already know the answer. Second thing, I like my life easier. So moral of the story, it is your choice how you have to take your path. Anyway, moving on, these are the basic things which you guys need to know about your ECG. We're done with P wave, QRS wave, T wave, PR interval and QT interval. We discussed how to find out the heart rate in the easy way or the hard way. Let's, guys, now talk about the squares. So just now I told you that easier way to find out the heart rate is going to be by counting the large boxes. Now, what is the value of these large boxes and the small boxes? See, guys, I will tell you one thing. One large box is equal to 5 small boxes. You will count over here. You will have 5 small boxes. This is like this. Sorry, this is just one line. Yeah. So one large box is equal to 5 small boxes, and each small box ka value is going to be 40 millisecond. Okay, one small box is equal to 40 milliseconds, and as I told you, one large box is equal to 5 small boxes. So 5 times 40 is equal to 200 millisecond. So one small box is going to be 40 milliseconds, and one large box is equal to 200 milliseconds. Now you need to remember what are the values of each duration. How long is P wave, how long is PR interval, QRS, Q, T wave and all. Now here also you have choice. One choice is you remember the boxes, easy way out. Second way is you remember the huge numbers. I remember the boxes, that's the easy way out in this, okay? Otherwise it is your swadhanusar, your choice. First thing what you have to know is the values. As I already told you in P wave, what does P wave signify? SA nodal conduction. P wave value is going to be less than 3 small boxes. So less than 3 small boxes, which means one box is 40. So 40 into 3 is 120. Duration is going to be less than 120 milliseconds of P wave. If a P wave is more than 120, it is going to be prolonged, okay? Next is PR interval. PR interval was nodal conduction. Remember, PR interval ka range is between 3 to 5 small boxes, which means 120 millisecond to 200 millisecond. 120 to 200 millisecond. The next is QRX complex. QRX complex, which signifies ventricular depolarization, the value is between 2 to 2.5 small boxes. 2 to 2.5 small boxes. In duration wise, it is going to be 80 to 100 millisecond. The next interval you will be having the long interval, which is the QT interval. QT interval is a combination of ventricular depolarization and ventricular repolarization. The value is between 9 to 11 small boxes. So 9 fours are 36. So 360 to 440 milliseconds for QT interval. And the T wave is a ventricular repolarization. And T wave, you don't have a duration, you actually see the height, okay? So the T wave, whenever you see it's a tall T wave, when you check the limb lids, when limb lids are more than 5, or when the chest leads, guys, is more than 10, that is going to be considered tall. So that is why you want a range which is less than 5 in case of the limb leads and less than 10 in case of the chest leads. Okay, so these are things which you have to remember with respect to the basic needs in case of ECG. I hope everything is clear till now. Next, guys, let's talk about some detailed facts. Now, guys, if you talk about the impulse, the main controller is your SA node. Maximum impulse is generated by the SA node. From the SA node, via its right branch and the left branch, it reaches the AV node. AV node is also known as the delay. Why? Because so that it can have a proper rhythm where the atria, the right and the left contracts properly, gives its time, and then the ventricles are going to contract. Hence, it's going to give you a delay. Slowest part of the conduction portion is AV nodal delay is your answer. From the AV nodal delay, guys, from there it is going to go to the bundle of His. From the bundle of His, which will be your right and the left bundle of His, it is going to go to the Purkinje fibers which are present in the ventricles. The Purkinje fiber, guys, is the site where maximum conduction speed takes place, and the value is going to be 4 milliseconds. Okay, slowest AV node, fastest Purkinje fiber. We're adding physio also, again integration. Other facts which you have to remember, guys, as I told you, P wave. Normal P wave value is going to be less than 3 milliseconds. Okay, so now, guys, P wave, right? P wave signifies two things. Your P, what it is, atrial contraction, correct? So P wave can be either right atrial contraction or left atrial contraction. So how do you find it out, guys? If you have a tall P wave, normal P wave ka height is 2.5 mm. Okay, 2.5 mm is going to be a normal like P wave. If you have a tall P wave, which means more than 2.5 mm, remember it signifies right atrial enlargement. It signifies right atrial enlargement. If you have a prolonged P wave, which is more than 3 small boxes, it signifies a left atrial enlargement. A left atrial enlargement. Okay. Other factors which you guys have to remember is your heart rate is inversely proportional to the PR interval. Okay, your heart rate is inversely proportional to the PR interval, which means scenario wise, if I'm running right now, if I'm in the gym, my heart rate is going to be very fast, due to which my PR interval is going to be short, less than 120 milliseconds. Okay, Q wave, guys, is the septal activation. We already discussed the value of Q wave is going to be one small box, which is 40 milliseconds. QRS, as we already discussed, ventricular depolarization, 80 to 100 milliseconds. Okay. Next slide, guys, we already discussed about the T wave, ventricular repolarization, normal height which we want. Now let's talk about the QT interval. Again, normal QT intervals, what is? It is ventricular depolarization and ventricular repolarization, value between 360 to 440 milliseconds. You need to remember the QT interval is inversely proportional to the calcium, which means if the calcium is going to be high, QT is going to be short. If calcium is going to be less, QT is going to be prolonged. Simple answer. So, guys, in case of hyperthyroidism or any condition in which there is hypercalcemia, too much calcium, like in sarcoidosis, what will be the QT? Because calcium is high, You will have a inversely proportional, so it will have short. Very good. You will have a short QT interval, okay, because it is inversely proportional. Tetany, in which you do the chopstick sign by touching over here to the cheek, that means hypocalcemia. So if calcium is going to be low, your QT is going to be prolonged. Very good. QT will be prolonged. Prolonged QT will be there, okay. That is the thing which you need to remember, inversely proportional ratio. Very good. Next, guys, we're adding each wave. So let's talk about one wave, which is J wave. Remember earlier we talked about a J point, which is an isoelectric point. Right now I'm talking about a wave, which is J wave. J wave is also known as your Osborn wave. You can see over here, it is an additional wave after your QRS complex, correct? So where do you see this J wave? J wave, guys, is seen in conditions of hypothermia. In conditions of hypothermia, remember, whenever hypothermia, a patient suffers from hyperthermia, any value less than 35 is considered as hypothermia. Patient can have his ECG. In case of moderate hypothermia, in case of severe case of hypothermia, you can get the J wave. Now, guys, J wave, which is there, right? You will be calculating the core temperature. Remember, guys, the core temperature is ideally checked in a better way from the lower esophagus than the rectal part, okay. Moderate grade of moderate type of hypothermia is usually seen at the temperature of 32 to 35. Less than 32 will be severe. That is the conditions. From moderate to severe, you get to see this Osborn or J wave. And whenever you're hypothermia, it's obviously, remember, we are using hypothermia to slow down everything, slow down metabolism. Hence, sinus bradycardia also is seen in hypothermia. What is the management, guys? You have to do active rewarming using peritoneal dialysis with the help of warm saline. Okay, you have to do active rewarming with the help of peritoneal dialysis with the help of warm saline. If they will ask you identify this is example of your Osborn J wave. So along with the history, along with this Osborn J wave, you can crack the diagnosis and make sure you know the answer as well. Let us integrate this with another anesthesia topic. Here this was hypothermia. Let's talk about now malignant hyperthermia. So guys, malignant hyperthermia is caused by multiple drugs, most of the inhalational drugs and a drug which is a muscular relaxant, which is your succinylcholine. The defect is in a receptor which is your ranodine receptors. Your ranodine receptors are responsible for the uptake of calcium. So when these receptors are defected, so much calcium comes inside, and you guys know calcium causes contraction. So if calcium causes contraction, tachycardia will happen, the heart rate increases, body temperature increases, the pain will increase. So everything causes increase, which is very dangerous condition, okay. The temperature is also going to increase by 41 degrees Celsius, okay. The drug of choice over here is going to be IV dantrolene sodium. Obviously, before that, stop the inhalation agent, stop the procedure, give the IV dantrolene sodium along with calcium, along with oxygen supplementation, okay. Talking about DOCs, I was just solving few questions. Let's add this also like in an integrated part. So drug of choice of alcohol de-addiction, if they will ask you guys, it's going to be acamprostate and naltrexone, okay. Acamprostate and naltrexone. What is, guys, delirium tremens? Delirium tremens is if someone all of a sudden has abrupt stop, like he had a chronic history of alcohol consumption and all of a sudden he's like, nahi bhai, aaj se daru band, and from 1 to 2 days he haven't had it. You will see he'll have symptoms of rage attack, patient will be having tremors, sweating will be there, the pupils are going to be dilated, and the patient is going to have palpitations. So this is basically your, and along with that hallucinations also will be seen. So this is your delirium tremors, okay. What is the management, guys? In case of emergency condition, if the patient is not taking oral drugs, you have to give IV diazepam, or also if the patient is accepting oral feeds, you will give oral chlorodiazoxide, okay. So that is your management with respect to delirium tremens. Let us bring now, so we got another integration between hypothermia and hyperthermia. Please make sure that you're studying this way so that you will remember your topics for a longer time, okay. Next, guys, let's talk about atrial fibrillation. So by simple words, guys, atrial fibrillation is a condition where the heart rate is very high. If you count over here, guys, obviously there is tachycardia, but that's not it. In atrial fibrillation, the heart is twitching, it's not contracting so much. So basically it's not pumping too much blood, but it's like, the atrials are just contracting, but blood is not getting flowed, okay. What are the features which you see in case of atrial fibrillation? First of all, you will see, notice one thing, that the R intervals are not regular. In some there are 2, some there are 3, some there are 4, some there are 4, 2, 2.5, then 3. So you're understanding one thing, you'll have irregular pulse. irregular pulse will be there. In the ECG also you'll see irregular pulse. But a classic feature over here, I can count the QRS over here, T wave is there, but there is no P wave. So what do you see? Irregular pulse, which means the 2 to RR intervals are not same in all parts of the ECG. Along with that, absent P wave, your diagnosis, guys, is going to be atrial fibrillation. What history they can ask you guys is, you'll have a chronic alcoholic, sharabi banda hai, who has dilated cardiomyopathy. Now, dilated cardiomyopathy means there is some dilatation in the atrium. There is a lot of small clots which are there. And guys, as I told you, these conditions, dilated cardiomyopathy, can precipitate conditions like atrial fibrillation. Features because of which you will see the heart is twitching so much, and it is firing these small clots at the rate of 300 to 600 beats per minute. Features will be irregular pulse. It is not beating and pumping out so much blood. That is why your BP is going to be low, and the diastolic might also not be recordable. The management is, atrial fibrillation is a very dangerous condition, so there is a race to treatment. Okay, you have to race quickly for the treatment. The mnemonic for the treatment is RACE, where R over here stands for rate control. You will be using a fast acting beta blocker, that is esmolol. You will be giving anticoagulants for the clots, which will be warfarin and rivaroxaban. Remember guys, what is the mode of action of rivaroxaban? Rivaroxaban has an X over here, so it is a factor 10 inhibitor. Rivaroxaban is a factor 10 inhibitor. So RAC stands for chemical cardioversion, and chemical cardioversion is done by an antiarrhythmic drug with the help of intravenous infusion, that is your amiodarone. If your chemical cardioversion is not working, now you will do your electrical cardioversion, that is your DC shock. Okay, the difference between cardioversion and the difference between defibrillation is, cardioversion fires at the RR interval. Okay, there is RR interval, that time only it will be firing. That's why this is electrical cardioversion and not electrical defibrillation. In case of emergency, guys, remember I was talking about defibrillation. In defibrillation, it is just firing at a random rate. Over here in cardioversion, we are firing at the RR interval. Okay, and the power in which this DC shock is going to be fired is going to be 200 joules. Irregular pulse, absent P wave, management RACE, which is rate control, anticoagulants, chemical cardioversion, finally electrical cardioversion. This is all what you need to remember with respect to atrial fibrillation. Next condition, guys, is going to be atrial flutter. Atrial flutter, classic thing which you will see is going to be sawtooth pattern. A classic feature which you see is your sawtooth pattern. Okay, so let's talk about all the sawtooths which you see in medicine. Sawtooth pattern in ECG, very good atrial flutter. Sawtooth pattern in barium anemia, let's get your surgery in. The diagnosis is very good. Whoever knows it, comment. Make sure that you comment and let everyone else knows. I really don't care if there are already so many comments, but it's your responsibility that you know the answer and you have to help others. Hence, comment below what is the diagnosis. Okay, where do you see sawtooth pattern in barium anemia? This is a highly repeated PYQ question. Another PYQ question is sawtooth waves which you see in EEG in the brain. That is seen, guys, in the REM sleep. Okay, that is seen in the REM sleep. All right. Over here also, guys, atrial flutter is also an emergency condition, so you have to race to the treatment. The management is exactly same. Okay, the management is exactly same. You have to do race, but the only difference over here is, as you come down to electrical cardioversion, guys, the management over here, the DC shock is not going to be 200 joules. It is going to be around 20 to 25 joules. Okay, the only difference between atrial fibrillation and atrial flutter treatment is, in atrial fibrillation you are giving 200 joules. Over here, remove 1 0, you're going to give 20 to 25 joules. Okay, again, that is all what you need to remember in case of atrial flutter. Now, guys, both of these conditions are very dangerous. Both of these conditions can form clots, and you guys know these clots can go to the brain and have a stroke. So what are the preventive measures that you can prevent? How can you see that there are clots? So if there are clots, you'll give anticoagulants. The diagnostic choice which we do is, you're going to do a transthoracic echo. You do a transthoracic echo, a 2D scan of the heart basically, and then you get to see that there are clots or not, like how I showed you here in the dilated part. Okay, so this transthoracic echo is very useful, but it is not useful if the size of the clots is less than 2 mm. If the size of the clots are less than 2 mm, this transthoracic echo cannot detect whether there is clots, and then we cannot detect whether we should give anticoagulants or not, because anticoagulants thins the blood, easy chances of bleeding, correct? So now, guys, over here, Okay, so now guys, over here you have to see what is the management. So if you have a transthoracic echo which is of no use of less than 2 mm, we need something for which we can make the judgment whether should we give anticoagulants or not. That is guys your CHADS S2 VAC, CHADS VAC score. Okay, CHAD S2, which will be VAC score, is the score in which you tell whether you need anticoagulants or not. Remember this, we already talked about this earlier, but in detail remember the whole thing, where C stands for congestive heart failure, H stands for hypertension, A stands for age more than 75 years, D for diabetes, S is going to be stroke, and S will be CHAD S2, because stroke is something which will be giving you, you will give 2 points, otherwise you will give 1 point. Okay, VAC will be vascular diseases like peripheral arterial disease, and sex category female. Any of this in your patient is positive, you have to give anticoagulants. The anticoagulant of choice is going to be warfarin or the factor 10 inhibitors, which are the exabans, rivaroxaban or apixaban. What are these guys? These are NOAC, which is novel oral anticoagulants. Method can be dual oral anticoagulant as well. Alright, again guys, what you have to remember is, you remember we talked about ABCD2 score. That was a score in case if a patient had a mini stroke, which was a feature. All of a sudden you had no loss of vision, all of a sudden opened his eyes, okay, he can see now. What is that? Amaurosis fugax, very good. In that condition, the score which was used was ABCD2 score. Very good guys. Okay, so this was all about your atrial fibrillation, atrial flutter and the check. The last topic which I would like to talk about is something which is known as PSVT. A patient comes with you with recurrent episodes of dizziness, palpitations. When you check the heart rate, so like 160, 170, 180. Okay, recurrent attacks of syncope. Many times when he went to the to the doctor, because he thought that this is a very dangerous condition, all of a sudden, it's not associated with any panic, but all of a sudden he's having these episodes, he went and did an ECG. The ECG many times came out to be normal. So the patient, the doctor must told, okay, it's okay, just don't take stress, do falana and do. But these episodes happened again and again. So now the doctor started figuring that this can be something, which is not detectable right now. So for that condition, what he did, he put a device which was Holter device. A Holter's device is a device which you put and it checks 24 hours throughout the day any arrhythmias or there any abnormalities in your ECG. So when you did that ECG in this patient X, over here what you guys found is, in the ECG anywhere you first found was a global ST depression. So you can see a very classic feature over here, anywhere a global ST depression, correct? Next thing you guys might notice is, it's a very narrow QRS complex. Remember, QRS is 2 to 2.5 small boxes. Over here this is just one small box. So narrow QRS complex. And another thing is, I'm able to count the P wave, the QRS wave, I'm able to count the T wave, but where is the P wave? You have a narrow QRS complex, you have a global ST depression, and you have an absent A wave, like hidden. A word right over here is used in hidden, because if you see the T waves are comparatively large, it overlaps. The P and the T wave overlaps in this condition. This condition, guys, is known as, very good whoever has answered the diagnosis, it is paroxysmal, not paroxysmal nocturnal, it is, sorry, paroxysmal supraventricular tachycardia. Okay, PSVT, paroxysmal supraventricular tachycardia. You're having a combination of, you'll have a global ST depression, narrow QRS complex, and an hidden P wave. Usually you cannot detect this in an like normal finding of an ECG. You use an Holter device and then you see. Okay, what are the management, guys? And very important, guys, the heart is structurally normal, which means when you do a 2D echo, so you won't see any abnormalities, you'll see the heart is structurally normal. That's why then you think about, there might be some issues. Recurrent episodes of syncope is a proper history they will give you, and over there then you will do a Holter device and then you find out the ECG findings. What is the management, guys? Guys, for the prophylaxis, you're going to give a calcium channel blocker, that is your Viramipil. All of a sudden, the patient was suffering from your PSVT, paroxysmal supraventricular tachycardia. What is the management? First thing is, I'm going to ask her or him to do a carotid massage. If you apply over here pressure, because the baroreceptors over here, it stimulates the vagus nerve, and vagus nerve decreases the heart rate. Step 1. Okay. If this does not work, then what you are going to do is, you can put a face pack also in the eye, a face pack around your face, an ice pack, sorry, not in face pack, an ice pack around the face. That the cold temperature is going to stimulate the vagus nerve. Again, the same rule. Okay. Talking about drugs, the drug which is given over here is going to be in an acute condition is going to be IV adenosine. 6 milligram followed by 12 milligram, again a 12 milligram dose. If this also does not work, in case of practice, in general clinical practice, you give a drug which is deltiazem. But if they ask you even after a medical dose failure, the next management is going to be DC shock. Okay, so what you did is to get to the rhythm proper. First thing, carotid massage. Second thing is going to be IV adenosine. Third thing is going to be your DC shock. The values are going to be 120 to 200 joules. Remember, please guys, in case of emergency, in case of, you know, a shockable rhythm like VT or ventricular fibrillation, you are giving 200 joules. Very good. In case of atrial fibrillation, 200. Very good. In case of atrial flutter, 20 to 25. And in case of PSVT, you are going to give it, the value is going to be around your 120 to 200 joules. Okay. Talking about the management, guys, again, if you talk about the prophylaxis, you're going to give Viramipin. If the BP is somewhat stable, more than 90 over 60, anything more than 90 over 60, what you have to do? Vagal stimulation, which will be carotid massage, ice pack, adenosine. If even adenosine, you give DC shock. Now, if the patient is crashing, guys, okay, if the patient is crashing, the BP is much more less than 90 over 60, that time you will not start doing over here directly this your carotid massage. You have to take it there very seriously. Okay, this is basically the patient is hemodynamically unstable. So in this condition, guys, directly start with your DC shock, value 120 to 200 joules. Correct? Differential diagnosis of PSVT with respect to psychiatric conditions can be, you'll have generalized anxiety disorder. But in case of generalized anxiety disorder, guys, the duration, the history is going to be more than 6 months. It is the most common psychiatric disorder that is going to be generalized anxiety disorder. A panic attack, guys, have similar features as well. Palpitations, tremors, dizziness, but then the episodes are going to be of 1 month. Okay, these are panic attacks. In case of management of acute anxiety, guys, you're going to give clozapam, you're going to give alprazolam for a dose of 2 weeks. Okay, and in case of non-habit forming, a non-sedative and anxiolytic drug, that is going to be your buciprone. Okay, these are also PYQs asked with respect to psychiatric as well as pharmacological questions. But if there is someone who's, you know, suffering from palpitations, if there is someone who's suffering from stress and anxiety, trust me, even I had it, I would not recommend you to take any medications, because once you start taking these medications, guys, it is going to be very hard to let go. What I would really suggest you is to talk to someone. If you don't have anyone, just text me or call me. I'll definitely pick up. I'll definitely talk to you guys. But the main thing what I would suggest you is start meditation. Don't start meditation all of a sudden, like, you know, at the end. Start it now, start it slow, because even if you don't have any problem, very good, make sure you take care of your mental health, because it's all on your mindset. Everyone has the same time, the same duration to study, and also the same portion. But how come some people pass, some people fail, some people top? It's all about their mindset. Okay. Lastly, guys, if you have a patient with neck stiffness, with like headache and, you know, fever, there are two next day, fever will be here. What is your diagnosis, guys? Tell me that. Okay, what is your diagnosis? Very good. And the last thing what I want to ask you guys is, whoever is stuck till this video, very good, I'm so proud. I want you guys to text in the comments or text me personally. I will not ask what are you texting. What will be your FMG score? If you are an FMG student right now, what will be your FMG score? Okay, I want a high expectation score, because if you will mark 150, trust me guys, your passing will be very hard. If you have a higher goal, if you have a stronger higher goal, chances of failing is going to be very less. And the power of manifestation is really true. Okay, power of manifestation is really true. Please mention below and manifest all the good things. Take care, guys. It was a very fun session. I hope you understood. If you have any other doubts, feel free to text me, and let's meet in the next video. Take care. Sayonara.